having me. My name is Kate McClure, and I'm from Columbus, Ohio. I have a private practice where I practice myopia management and specialty contact lenses. I'm also part-time faculty at The Ohio State University. I'm going to lecture about myopia management, navigating the challenges. Here are our learning objectives for the lecture. So we're going to cover some very specific questions that we might want to know about myopia management. So first, when you consider prescribing for myopia management, is there a baseline in prescription that you're looking for, or a certain change in prescription that's meaningful to you? What are the risk factors involved for a child developing myopia or having a progression of their myopia? What are the current therapies that we have available? How do we choose the appropriate therapy for each patient? And then, how are we going to educate our parents and patients about the selected therapy? Also, what are the current contact lens therapies that we have available? And how can we prescribe for the challenging astigmatic patient? So during this lecture, we will answer all these questions. To do so, I'm going to go through 3 different cases. All cases are handled very differently in prescribing for myopia management and will help us navigate some of these challenges. First, let's talk a little bit about the different myopia management therapies that are currently available. We have bifocal glasses, low-dose atropine, multifocal contact lenses, orthokeratology, or a combination of therapies if needed. In my practice, I do prescribe low-dose atropine, multifocal contact lenses, and orthokeratology. Those are the 3 therapies that I use most often, and sometimes I'll use a combination if needed. Now, this lecture will focus on multifocal contact lenses and orthokeratology. Our first case here is a 9-year-old female. And she comes in wearing glasses, and we can see she's already highly myopic with some astigmatism. Her entering acuities are reduced. She's 20/50 in the right, 20/40 in the left. Now, I did a refraction and found a significant change in her prescription. She's progressed about a diopter in each eye with some change in her astigmatism. She does easily correct to 20/20 in the right and the left eye. Now, of note, I did confirm the prescription with the cycloplegic refraction. I wanted to ensure that I hadn't over-minus my patient and it was a true change in prescription. So I do like to check the prescription post-dilation for my patients. Also of note, unfortunately, I do not have axial length measurement available at this time. Now, prescription is closely correlated with axial length, so I do use a prescription and progression to determine if they have a progression of their nearsightedness. Anterior and posterior segment were all normal, and the patient was slightly exophoric at near. I had a chat with the patient to see what she might be interested in, and she said she really wanted to wear contact lenses for Taekwondo and may wear them for school and more often if she really likes them. So what do we think about this patient's progression of their myopia? She's progressed about a diopter. Should we consider discussing myopia management? Is this a significant change in prescription? And what are the risk factors for this patient? So let's answer some of these questions. First, let's assess the patient's risk. So I like this graphic from the Brian Holden Vision Institute because I think it really helps give a good overview and understanding of increased risk of onset and increased risk of progression. The increased risk of onset is if both parents or one parent is myopic, if the patient is of East Asian ethnicity, if they're more myopic than age normal or have progressed more than 3/4 of a diopter per year, if they do excessive near work, and limited time outdoors. So all of these put the patient at increased risk of onset of myopia. So next, the increased risk of progression includes age 9 years or less when you first diagnose them with myopia, if they have one or both parents that are myopic, once again, if they're more myopic than age normal, or progression worse than 3/4 of a diopter per year, and a patient of East Asian ethnicity. So all of these put the patient at increased risk for progression. Looking at our patient specifically, she's age 9, already highly myopic, puts her at increased risk for continuing to progress. And we know that this year she's already progressed more than 3/4. She's progressed a diopter in the year. Now, if you want to break these risk factors down for the parents, there's several good resources to do so. I really like this risk analysis from mykidsvision.org. This is geared to your parents, so your parents will go on and they will put in their child's information, and it will help outline their child's risk for myopia. And I really like it because it's in words the parents will understand, and therefore they will have a better understanding of the treatments and the importance. There's also a Spanish version available. So this is a great tool to use in your clinic so that the parents are well informed and understand the risk of myopia. Looking back at our case again here, so we have this prescription and we know that our patient has a couple risk factors, her age and progression. Okay, so we know these things. Now where do we go next? What do we do? So I advise that you start with a myopia management evaluation. So you've done your comprehensive exam and updated the patient's prescription and made sure their eyes are healthy. Next, I advise that you schedule them for specific myopia management evaluation. Now, what should be accomplished during this evaluation? A couple of really important things. First, this is going to give you time to provide education on myopia and the myopia management therapies. You can also set expectations. You want to make sure that you're setting the expectation that you're aiming to slow the progression of the nearsightedness. You may not stop it, and you definitely won't reverse it, but we want to slow it down. So you need to set that expectation from the beginning so the parents aren't disappointed. This also gives you the opportunity to complete and discuss any necessary testing and measurements, and then you can initiate a therapy. So for our patient, I started with a myopia management evaluation. I provided education on myopia and the therapies. The parents understand and they're really, really excited about myopia management and slowing their child's nearsightedness. The child is very motivated to wear contact lenses. So the parents want to pursue a contact lens option. Now, I did discuss atropine drops, and they weren't really interested. The parents knew that they wanted to invest in contact lenses for their child, and they were unexcited about atropine because of the added cost. So they really felt like they could afford to pursue one thing, and they wanted to pursue contact lenses. Okay, so we have the prescription and then the horizontal visible iris diameter. This is a really important measurement anytime you're prescribing contact lenses. So you can see that the patient's horizontal visible iris diameter is a little over 12 in the right and just under 12 in the left. So average is about 11.5. The patient has normal pupil size. Looking at the topographies, we can see here that she has regular with the rule astigmatism. There's a diopter and a quarter, a diopter and 3/4 in the right average and a little over that in the left. So you can see here fairly regular topography, nothing exciting, but she does have significant corneal and refractive astigmatism. Okay, so is orthokeratology an option for our patient? And to understand if orthokeratology is an option, we first must know a little bit about the parameters that we have available. And I will say it somewhat depends on the lens design that you choose and the manufacturing lab that you work with. Each design is a little bit different, but I've outlined here the average parameters that are included in most designs and the one that I use. So for the prescription parameters, it's really important that we understand that this is prescription parameters for the spectacle RX before you vertex. So we want the sphere for the spectacle prescription to be less than or equal to -5. For the astigmatism, we want less than or equal to -1.5 with the rule or -75 against the rule. Now, K values are also really important. We want the flat K value to be between 40 and 46 diopters. Now, there's one other issue with that, is that the Ks must also be steep enough to allow for treatment. Once again, talking about the flat K. So for every diopter of myopia, we're going to need a diopter of central flattening. The minimum K I like to flatten the cornea to is greater than or equal to about 38. So for example, if you have a patient that's a -4 myope and their flat K is 44, you're going to flatten on an average about 4 diopters to bring them to a 40. That's above 38, and I'm perfectly comfortable with that. Now, if your 4 diopter myope has a flat K of, let's say, about 41, that's going to take us below 38, and I'm not comfortable prescribing for that. I think that would impact our success. So really important that you look at the prescription parameters and the K values and the flat K value to see if orthokeratology is a good option for your patient. Also, obviously, we want the patient to be without corneal disease or abnormalities. So we need to take all of this into consideration. So what contact lens design can we consider for this patient specifically? We want to make sure we set expectations. So I outlined early on for the parents and set the expectation that orthokeratology was not an option. We'd have very limited success for a couple of reasons. The corneal astigmatism is high. It's over 2 diopters in both eyes. And the patient also has high myopia. So -625 in the right and 7 in the left. That's outside of our standard parameters and likely wouldn't be very successful. Also, the patient's Ks are not steep enough to allow for treatment. So the flat K in the right eye is 43.29. If we need to flatten the K 6.25 diopters, that's going to take us below the flat K of 38 that I like to see. And same thing in the left. So based on the patient's prescription and her keratometry values, I really don't think ortho K would be successful. Now, we could consider a soft lens multifocal. We need a couple of things. Anytime we're doing myopia management, we need a center distance design. And for this patient, I'm also going to need astigmatic correction. I decided to do a custom toric multifocal for this patient. I used her refraction, Ks, and HVID to empirically order a lens. You can see the parameters I have listed here. Specifically, I ordered a +250 center distance add with a near zone of 3.5. Now, I did empirically order a lens, and I like to do this for many of my children when I'm first fitting them in contact lenses, if their prescription is outside of my normal parameters. A couple of reasons. Whenever I first put a contact lens on the child's eye, I like it to adequately correct their vision so they can see clearly and they have a good first experience with contact lenses. So it's important to me to have a contact lens that they'll be able to see well out of. So I empirically ordered this lens for this patient. We dispensed it and I encouraged her to wear it 9+ hours a day for at least 5 days per week. Now, why would I mention this? Does wear time impact efficacy of the treatment? And it does. So keep in mind, for contact lenses, soft contact lenses in particular, the treatment only works when the patient is wearing the contact lenses. So if she's only wearing the contact lenses part-time, maybe 3 days a week, she's really only getting the treatment 3 days a week, and that's not sufficient. So I wanted to make sure that the parents knew that the child really needed to wear the contact lenses most days of the week, pending that the contact lenses are comfortable and that her eyes are healthy. And when I dispensed the lenses, they looked really good. So at the 2-week follow-up, the patient loves her contact lenses. She reports good vision and good comfort. She's worn the contact lenses since 7 a.m. that morning, so she's had 9 hours of comfortable wear time. Her vision in the right eye is 20/25 plus. The lens is well fitted. It's centered, has about half a millimeter of movement with no rotation. I did an over-refraction and found plano. And the left eye, she was 20/25 minus. And the lens was fitting well, same thing, well centered, half a millimeter of movement, and about 5 degrees right rotation. I did find an over-refraction that gets the patient to 20/20. I decided to modify the left lens only. So you can see here that I basically incorporated the over-refraction. Now, when do we want to follow up with this patient again? So anytime I've established that a patient is in a myopia management therapy and they're doing well and I'm thinking we're going to have good success, after I've established that the initial treatment's working well, generally I'll follow up with the child in about 3 months' time. At that 3-month follow-up, there's some questions you need to consider. So what if the patient's myopia continues to progress? How much progression would concern you? Would you change therapies? Would you maybe add a therapy? These are all things we need to think about when we're scheduling this 3-month follow-up. So for this patient at the 3-month follow-up, she was 20/20 in both eyes. I have no over-refraction of the lenses. The patient reports, once again, good comfort, good vision, and good compliance. Also, the lenses were still fitting really well, and I was happy with the way the lenses were fitting and her eye health. Now, luckily, this patient didn't progress. I assume so based on the stability of her vision and the fact that I found no over-refraction of the lenses. So, what if her myopia did continue to progress? Would I want to modify the current therapy or change therapies? Or would I want to add a therapy? So for this patient here, I still think that we have some things that we could do with the contact lenses. So I would want to modify this therapy before changing it. This patient's in a custom designed soft contact lens, which is great because it means I have the ability to change parameters if I need to. I had the patient in a +250 add, so I could change her to maybe a +3 add to see if that slows her progression more. I could also change the zone sizes if needed, so I could look more closely at her pupil size to see if I got an incorrect measurement their first time, and then I could change the zone sizes too. So because I still have the ability to change some of this treatment, if she continued to progress, I would probably try to modify this treatment before switching or adding another. Now, I could always add low-dose atropine to her therapy if needed, but once again, the patients would incur an extra cost, and that might not be an option for these parents. So you really have to find what works for your families, what they can do and they can adhere to, and what's going to be best for slowing the progression. So let's look at a case that's a little different. So this is an 11-year-old male, Asian male, who presents for myopia management evaluation. He's currently on therapy of low-dose atropine. Mother is really, really motivated for Ortho K. Now, he's already previously failed an Ortho K with another provider. He had inability to wear the lenses secondary to discomfort, and his vision was never very good. Now, the patient's motivation is questionable. He doesn't seem excited about wearing Ortho K lenses, and he doesn't really want to pursue contact lenses all that much. Now, the mother is very motivated and insists that we at least try. So let's look to see if he's a good candidate. I have his glasses prescription listed here. Now, this was a new patient to me. I had not done his annual exam. So this is the information I had provided to me. Now, mother did bring his glasses prescription from last year, and he did have about a diopter change in each eye. So I can see why she's still concerned about the patient's progressing myopia. I measured HVID, which is slightly on the smaller side of average, a little under 11 in the right, a little over 11 in the left. We're going to look at topographies in a minute, and his anterior and posterior segment was all normal. Okay, so first let's assess this child's risk. So a couple of things. He's older than 9. However, his mother is myopic. He is of East Asian ethnicity, and his refractive error is more myopic than age normal, and he's progressed more than a diopter per year based on the information I have available to me. So I can see here that we do have 3 risk factors, and I think the risk is significant for progression. Looking at the topography here, we can see regular with the rule astigmatism. And what I'll note here, so here's our axial map, and then our tangential map. What's interesting is that the astigmatism is fairly well contained to the central portion of the cornea. I like to call this apical astigmatism. So it doesn't really look limbus to limbus, it's more contained centrally. That's of note in the treatment that we decide to pursue, so I'll talk about that more in just a moment. So looking at this patient's information, what are the potential challenges that we might have with Ortho K? So the patient does have corneal and refractive astigmatism. He has a diopter and a quarter of refractive astigmatism each eye, and then a little bit more corneal in each eye as well. Now, once again, the astigmatism is with the rule and appears to be fairly apical. Apical astigmatism is contained within the central 4 to 6 millimeters of the cornea. That's different than limbus to limbus astigmatism, which is pretty much going to extend almost limbus to limbus outside of that central 4 to 6 millimeters. The patient's HVID is also on the smaller side of average, which makes Ortho K a little bit more challenging. Now, on the positive, his myopia is less than 5 diopters. He's minus 325 in the right, minus 375 in the left, and his Ks are steep enough to allow for treatment. That would put him a little over 31 in both eyes. Okay, or pardon me, 41 in both eyes. All right, so for this patient, we need to make sure that we set expectations. So I told the mother that we likely have limited success due to the astigmatism and the fact that he was a previous non-adapt. So I'm a little leery to pursue Ortho K, and I tell her this, that I think that's a good possibility that we may not be successful because there wasn't success previously. Mother knows the expectations, and she does want to try and she does want to pursue. For this patient, I did an empirical, custom-designed Ortho K lens. Some of the information is proprietary, but you can see here I have some parameters listed. Now, why did I decide to do a spherical design and not a toric Ortho K design? So looking once again at the patient's astigmatism here, it's fairly apical and contained within the central cornea. So I felt like we could flatten most of that astigmatism with a spherical lens and the central portion of the treatment zone. So I was I was fairly confident that I'd have good success with a spherical lens, so I wanted to try that first. Certainly could try a toric lens, but in this case, I wasn't sure that I would need it. Okay, so I dispensed the lenses. They were well centered, there was a nice bullseye pattern to the fluorescein, and there was a small bubble in the reverse curve, but they had good edge lift. So overall, I was fairly happy with the fit. Over refraction was plano in the right and left eye over the lenses. Now, let's take a minute and look at the lens power. My lens power is plus 75 in each eye. Now, my lens power is plus 75 because these lenses overcorrect by minus 75. I want the patient to maintain good vision all day long. So if we overcorrect a little bit, the treatment will wear off during the day and the patient will retain good vision even on into the late afternoon and evening. So because we slightly overcorrect, I incorporate that into the lens power so that when I'm doing an over refraction over the lenses to see if they're adequately going to correct the vision, I can get a plano over refraction. So I think that's really helpful. Now the patient is able to insert and remove the lenses. He does have a lot of struggle, but he's able to complete successfully with mom's help. Okay, so I dispense the lenses and I see him back first thing the next morning. Day one, he's 20/70 in the right eye, 20/60 in the left eye. And with my refraction, he's about a -2 in the right, 175 in the left. Easily corrects to 20/20. Luckily, looking in this anterior segment, it's very healthy. And let's look at the topography. So you can see here in the right eye, we're already starting to formulate a really nice treatment zone, centrally contained inside that right ring. Do have a little bit of central islands and some astigmatism, but overall, pretty well-centered treatment, and I'm happy with the right eye. Left eye, same thing. We have a nice treatment zone forming, definitely some central islands and some corneal astigmatism, but overall, the lens treatment's well-centered, and I'm pretty happy with what I see day one. I instructed the patient to continue nightly wear, and I didn't make any changes. And often I don't after the first night. Now, 1 week later, the patient's 20/30 in both eyes, 20/20 with both eyes together. I did find -75 refraction in each eye. Once again, his anterior segment is healthy. Okay, so looking at these treatments, overall, I'm pretty happy. The right eye, definitely still forming a nice treatment zone. I do have some residual astigmatism. The treatment's a little bit laterally decentered, but overall, I'm pretty happy with the week one results of the right eye. Now, very similar in the left. Treatment is a little bit decentered inferior temporal.
OneFitMed es un lente escleral delgado hecho a la medida que le permite a usted personalizar el diseño para cada ojo, logrando una oxigenación adecuada a la córnea y a las células madre.
Hello, everybody. My name is Jason Nichols, and I'm the program chair for the Global Specialty Lens Symposium and our new meeting, the Global Myopia Symposium. We look forward to bringing you cutting-edge information each year. And again, we look forward to hosting you in 2021. Thanks, everybody.
Overall, a nice treatment ring is forming, and we do have some residual astigmatism. So overall, for my week one results, knowing that we're going to have a little bit more challenges with this case, I'm pretty happy. I instructed the patient to continue wear, and I didn't make any changes. I scheduled a 3-week follow-up. Now, typically with Ortho-K, I'll do 1 night after their first night of wear, 1 week, and then 1 month later. Now, if I'm a little bit unsure about the treatment that we're getting, or if I have any hesitations, I'll usually see them back a week sooner than that, about 3 weeks later. So the patient's 20/25 in the right, 20/20 in the left, and I have +1/4 refraction in the right, -1/4 in the left. I had the patient put the lenses in, and once again, plano over refraction. His anterior segment is still very healthy. And looking here, you can see that the right eye a little bit lateral decentered, but overall, I'm actually pretty happy with that centration. We have a nice treatment area. However, I do have some residual astigmatism in that right eye. Left eye, a little bit more decentered temporally, no residual astigmatism, and a nice area of treatment has formed. So, do I want to make any changes to this fit? Now, there was residual astigmatism in the right eye. However, that treatment zone is fairly well centered, and the corneal astigmatism was borderline treatment, and he did have a little bit more corneal astigmatism in the right eye pre-treatment than he did in the left. His vision is 20/25 in the right eye, and there is only plus a quarter over refraction. So for these reasons, I didn't really want to change the right eye at the moment. Now, in the left eye, the treatment zone is slightly decentered, but the patient has good vision, 20/20, and a minus quarter over refraction doesn't help. So looking at these topographies here, overall, I'm actually pretty happy with this treatment. And looking at our results, I think the patient has good vision. So some of this is balancing, getting this fit, getting the topographies perfect versus getting adequate vision and good centration of the treatment that you're having. So it's all a little bit of a balance. And overall, I felt like I wouldn't be able to make any significant changes that would have an impact to the treatment. So I decided that this fit was complete and that I was really happy and I wanted to continue to watch the patient closely, but I wasn't going to make any changes at that time. So you can see there how I handled that astigmatic patient slightly different from our first. Now I have another astigmatic patient we're going to look at. Here I have a 10-year-old female. She also comes to me for myopia management evaluation. However, she is an established patient to my practice, so I have a full refractive history and health history for this patient. She is motivated to pursue contact lenses, and she's really excited about that thought. Now, mom is myopic and previously wore gas perm lenses, and that's of interest. So I find that sometimes the parents and their contact lens experience kind of sways their decision on what they'd like to do with contact lenses. So sometimes parents who've worn soft contact lenses are more familiar with those and are interested in pursuing an option for myopia management that includes soft contact lenses. Now, if the patient's parents have worn GP lenses or maybe no contact lenses at all, sometimes they're excited about Ortho-K. Now, I think I have all kinds of patients wearing Ortho-K versus soft lenses versus atropine. So it's really about talking to your parents and patients and finding the treatment that's going to work best for their family. So it needs to be an open conversation. But ultimately, you want to make sure that you're prescribing the treatment that's going to be best for the patient. So looking at the patient's glasses prescription here, and then her new manifest refraction, you can see that she's had a significant change in her prescription. Her HVID is slightly larger than average, and anterior and posterior segment are all normal. Okay, so once again, we need to assess the risk for this patient. This patient has several risk factors. Her mom is highly myopic, and she's progressed and has significant myopia for her age. She's over the age of 9, and she's not of East Asian ethnicity. So this patient does have 2 significant risk factors for an increased risk of progression. So I'm fairly confident that if we don't intervene, this patient's myopia is going to continue to progress more than we would like. Looking at the topographies, we can see that this patient has regular with the rule astigmatism in both eyes. She has just under 2 diopters in the right corneal astigmatism and just over 2 diopters in the left. Here's my tangential map as well. I'm not feeling super confident about the results with some of these maps. The patient does have a little bit of dryness, it seems, so I didn't get the best quality scan here, but overall, the astigmatism is looking regular and fairly limbus to limbus as well. So I wouldn't consider this one as much apical, a little bit more limbus to limbus than the last patient that we had. Okay, So for this patient here, I discussed the different myopia management options. We've got low dose atropine, custom soft multifocal, and ortho-K. Those are the three that I'd like to consider pursuing for this patient. Now, mom is really interested in contact lenses. She knows her daughter wants to wear contact lenses. And I had the discussion about the astigmatism and how it may limit the success of some of our myopia management designs. So mom says, "Yep, we can try contact lenses," but she understands that if it doesn't work or that if the patient can adapt, that they'll do low dose atropine. So after a discussion, the patient and the parents are motivated to pursue ortho-K. Now, once again, I had to discuss expectations. It's going to take longer to achieve treatment because of the patient's astigmatism, and she might have some residual astigmatism. So I said, "I'm excited to try this. I just want to let you know that we may take a little bit longer to get to the full treatment, and there might be some residual astigmatism. There's a possibility that this astigmatism will limit our success, and we may have to try a different therapy, but I think ortho-K is definitely worth pursuing for the child." I ordered a toric ortho-K lens design with a diopter and a half of toricity in the right and the left eye. I ordered a custom empirical proprietary design with a 10.6 diameter and a plus 75 power. The lenses were dispensed with success, so the patient was easily able to insert and remove the lenses and care for her lenses. I followed up with her the next day, the first morning, and you can see here that she's minus 250 in the right, the diopter is still, minus 2 in the left with half a diopter still. So overall, we've done a pretty good job at correcting her vision just day one. Once again, I didn't get the best quality topography scan here, but we can see that we're already starting to formulate a treatment zone in the right eye. Looks pretty well centered, a little bit superior centration, and about 2 diopters of corneal astigmatism, and that's coming from some of our central islands. But overall, looking pretty good. Left eye looks a little bit better, so the treatment zone is a little bit more well centered, and we're already starting to formulate a nice central treatment zone. So overall, I'm happy with the results of this topography day one. I had the patient continue nightly wear and followed up a week later. Now she comes in really excited because all of her glasses are too strong and she can see really, really well without wearing any glasses. She's 20/30 in the right, 20/25 in the left, and 20/20 with both eyes together. And for her refraction, I found minus a quarter, minus 75, axis 180 in the right, plano minus 75, axis 173 in the left. So overall, week one, really happy with her prescription results. Right eye, this treatment zone is really well centered. I have a little island of treatment there, but overall, nice treatment zone, really well centered, happy with that. About 3/4 diopter residual astigmatism. Left eye, same thing. I have a well-centered treatment zone, a nice treatment area forming, a little over a diopter. So overall, with these week one results, I'm really, really happy. Patient is seeing well, her and her mother are really happy, and we can see here that we're already starting to form a really nice area of treatment on the patient's central cornea. So her residual astigmatism week one, like I said, 0.74 in the right and 1.02 in the left. But the treatment zone is well centered, so I continue to have the patient wear the lenses nightly. And I'm going to follow up with her in about 3 weeks a little bit more closely to see how she's doing. But overall, I'm happy and I'm encouraged that we'll be very successful with this patient's toric ortho-K contact lens. So I've not yet seen that last patient for her follow-up, but soon I will see her and hopefully have good results to report. So you can see here that I've taken 3 different patients who are all fairly challenging myopia management cases. They're all astigmatic. However, I've treated them each very differently. So the first patient, put her in a soft multifocal design because of her keratometry values, her amount of myopia and astigmatism. And the second patient, I was able to use a spherical ortho-K lens to correct for his astigmatism. And then the third patient, I had to do a toric ortho-K design. So 3 different methods, all in which have been successful for our patients, not only in correcting their vision, but also slowing the progression of their nearsightedness. So in conclusion, there's a couple of things we want to keep in mind. You must educate. Educate on the risk factors for myopia. Educate on the risks with progression. You want your parents and patients to understand the myopia management therapies and find one that will work best with their child. So you really need to have a conversation because the treatment that works best is the treatment that the child will do. You want to make sure that you set expectations. Set expectations that we are trying to slow the progression of the nearsightedness and that we may need to modify or add therapies as we go along. And keep in mind that you do have contact lens options for your astigmatic patients. So I hope you've learned something from all 3 of these cases, and I'm really glad that I got to share them with you. Thank you for ContaMac for having me, and I hope you'd enjoyed this lecture.